Nurses and doctors of Reddit. What is your they never taught this in school moment? Story 1. I am not a nurse or doctor, but years ago I participated in a program called clinical rotation. Each student would rotate through different hospital units and shadow a nurse, doctor, or other medical staff, basically just follow them around while they did their jobs. Occasionally, we could help with simple tasks for some hands-on experience. Every day I got sent to a different unit. It was honestly the coolest experience ever. I've always been fascinated by medical science and human anatomy. One day, I was sent to the hospice unit. I was shadowing a kind nurse, walking with her from room to room, patient to patient, exchanging small talk and asking questions along the way. We came upon a very old, very grumpy man and were immediately hit by the unmistakable smell. Well, it turned out that it was this nurse's job to clean up the mess, change the sheets, get him fresh bedding, new clothes, and yes, bathe him. We got him into a chair and wheeled him into a large walk-in shower room. I was uncomfortable, to say the least, but I tried to be as professional as I could be in a situation I had absolutely no preparation for. The nurse asked me to help lift him off the chair so he could grab onto the railing, allowing her to clean his legs. As we helped him to his feet, he was still kind of crouched, one hand on a knee and the other on the railing, and that's when I saw it. The longest, most wrinkly thing I had ever seen. It had to be at least 1 or 2 feet long. It was straight out of a comedy movie. I was completely taken aback, frozen in shock. I am sure my face said it all because the nurse just smiled, trying not to laugh. I guess as a young adult, I had never really thought about it. I knew skin sags with age, but to that extent, gravity does its duty, apparently. She cleaned him fairly quickly, and we set him back in the chair. I swear that image is forever burned into my brain. So I just wanted to say, to that nurse and all others out there who have to go through that daily kudos, you deserve a freaking gold medal because I honestly could not do it. So I thank you. Before we continue, do us a quick favor. Smash that like button and subscribe to support our channel. Story 2. CNA here. I know I might not fit the typical storyteller bill, but I am sharing my experience anyway as a healthcare worker. Sometimes, even when you do everything you're told and do your job correctly, things still go wrong. You will care for an elderly patient you know will fall, and there's little you can do except try to lessen the damage. You'll form a bond with a patient's family member and feel hurt when they blame you for something. You'll trust your superiors and may end up thrown under the bus. I had one instance with a new patient who arrived on my day off. The nurse gave me a very quick report, saying that although he might be a little resistant, he wasn't combative. She added that he had been purposefully assigned to me because I am a calm CNA and chat with my patients, so they usually feel comfortable with me. We were short-staffed as always. The second shift was supposed to have 9 to 10 people, but that afternoon we had only 5 to cover approximately 115 beds. I had another CNA assisting me with this gentleman for a transfer, but he had to leave to get an oxygen canister and never made it back. My patient grew restless while we waited. I couldn't move him in his wheelchair because he was hooked up to a mounted oxygen tank, and I couldn't leave him alone. I stayed with him, calmly chatting to keep him settled. Out of nowhere, with no warning, he punched me in the eye. My glasses broke and I was stunned. I pulled the call light, nothing. I looked out the door, but there was nobody around. I had to use a phone to call the front desk and beg the nurse to come down, explaining that he had hit me and I didn't feel safe being alone with him. It still took her 15 minutes to arrive. It's been a few months now. I've lost central vision in that eye and have started seeing spots and floaters in the other. They'll probably take my license soon. I've seen several doctors and specialists, but they're at a loss and don't think anything can be done. Severe macular puckering with scarring. Surgery wouldn't help because the rods and cones are essentially dead. On top of that, I have daily migraines now. I wanted to go to school to be a nurse. I was working 60 hours a week at a job I loved, helping people, and now I take care of my husband while he waits for a disability decision. I am not even 30, and my life changed in an instant because of an injury. Protect yourself. Little things can change your entire life. Story 3. If you have a patient in labor or undergoing any painful procedure who wants to hold your hand, only let them hold 2 fingers. They can't squeeze too hard and break the bones, but they still get the comfort of human touch. I've had patients pinch me, pull on my clothes, and squeeze my 2 fingers as hard as possible. Sometimes they're just panicked. Other times they seem angry and want to hurt someone. I calmly ask them to stop pinching or pulling on my clothes because it isn't helping. These patients often refuse an epidural due to a fear of needles, which I understand, but I am not going to end up black and blue. I always teach new nurses and students the 2-finger trick. This reminds me of a couple who came in for delivery several years ago. I asked what method of pain control they preferred. They looked at each other, giggled, and then he said, "She bites me." I asked for clarification and learned that during her first 2 deliveries, when the contraction pain became unbearable, she would take his hand and literally bite down on his knuckle. They were both aware of this plan and, oddly, proud of it. Fast forward a couple of hours. Labor was well advanced. I looked up from a vaginal exam just in time to see her clamp her teeth on his calloused knuckle, biting with full pressure. He made a face but didn't make a sound. And thus, we ushered their youngest into the world. Each contraction, she'd take a deep breath, push to the count of 10, and bite down on her husband's hand. It worked for them, so who am I to judge? But I admit it made me somewhat uncomfortable. Story 4. I think it's incredibly important for medical staff to have access to standardized patients, trained individuals who act as patients with scripted backstories in staged office or hospital settings during their education. I've done that work myself, and I recall one particularly intense case where a student had to explain to the patient that their unborn child had died. In that scenario, we were instructed to become emotional, and watching the student's reaction as we launched into sobs was like reality hitting them with a ton of bricks. The tears, the grief, they were real, and it completely caught the students off guard. We were instructed to ask things like, "Did I do something wrong?" and "Is there anything we can do to save my baby?" It was hard to watch the students struggle with how to respond. So much of their training focuses on facts and statistics, but they need to learn the empathy side too, while maintaining a healthy emotional boundary. For some, it was a real wake-up moment. They realized this isn't abstract, it's someone's real life they will be diagnosing, treating, and supporting, sometimes even at the end of it. Another case involved portraying an SA survivor who had turned to alcohol to cope over the years since the assault. If a student finally identified the root cause of the drinking, many did not. They got stuck on the alcohol itself. We were instructed to cry and say things like, "I shouldn't have been at that party, and it's my fault, I was flirting with him." It was incredibly hard to enact, but it forced the students to confront difficult conversations. I was proud of many of the students. Most handled it well. Even when they didn't know exactly what to say, they remained outwardly calm and carried on. I hope these experiences helped ease the shock of similar situations they will encounter in real life. On the other hand, I also gave a lot of students pointed feedback, ranging from advice like, "Be more careful with your wording," such as XYZ, to, more bluntly, "Are you kidding me?" Story 5. I think the most important thing I've learned is how to support the family of a dead or dying patient. Working in the ICU, I see death so often that I've become almost numb to it. I've witnessed both the best and worst ways families respond to the dying process. In the best case, I cared for a family whose father had stage 4 end-stage liver cancer with metastases to the lungs and pancreas. He was in terrible pain but exhausted after years of chemotherapy and treatment. Eventually, he decided he had had enough and chose to move to comfort care, which means withdrawing invasive treatment and focusing only on pain control. The patient, let's call him Bill, whispered, his voice barely audible as his body continued to wither. He told us he was ready for comfort care and asked that we contact his family. The staff agreed, and we called them. His family came. One by one, his sons, daughters, grandchildren, and even great-grandchildren entered his room to say goodbye. Each shared a quiet moment with him, offering a hug and a few final words. Before he passed, Bill had one last wish, to share a glass of wine with his family. His son didn't hesitate. He got in the car, drove to the nearest store, and returned with the cheapest boxed wine he could find, Franzia. Together, they poured glasses and sipped, laughing and crying, sharing stories, and soaking in the presence of their beloved Bill. Not long after, surrounded by family and love, Bill slipped away peacefully. What stayed with me most from this experience was how Bill's family responded as he was dying. They weren't saying things like, "Come on, Bill, you're gonna beat this, keep fighting." Instead, they gently reassured him, "It's okay, Bill, we love you so much, you don't have to keep fighting anymore." They all understood that his body was failing, and so did he. Before he passed, Bill's entire family was present, cherishing their time with him until the very end. While there was mourning, and rightfully so, there was also a profound sense of joy and peace. Now the worst case. We had a patient, Jen, who also had end-stage lung cancer with metastases to the liver and bones. She was in constant, excruciating pain from her disease. The only sound she made was a moan with each breath. Because of her condition, Jen required aggressive blood pressure support and a BiPAP mask to help her breathe. Her family was adamant about pursuing aggressive treatment, believing her condition could somehow be fixed. Even after an extensive explanation of Jen's prognosis and the inevitability of death, they insisted we continue every possible intervention. So we did. What struck me was how, despite clear discussions, the family could not accept that end-stage cancer is not curable and that bone and liver involvement devastates the body. Jen herself was moaning in agony, but because she could not speak in complete sentences, her wishes could not guide her care. Instead, we had to follow her family's direction, prolonging her suffering. The staff could not look the family in the eyes because each of us believed what they were doing was both cruel and inhumane. Eventually, Jen passed, and her family remained upset with the staff for not making her better. They turned on each other, yelling and criticizing one another for things as distant as missed events from 25 years ago. Instead of peace, all we saw was anger. I was never taught in school how to handle such complex family dynamics. No one explained how to navigate these difficult conversations with both honesty and compassion. Working in the ICU, I see death every day, and I have come to realize that while grief is always present, there can also be joy. Death is 100% certain for all of us, but I have seen firsthand that even in dying, there can be peace, love, and even joy. TLDR, we all die, and I was never taught how to navigate the emotions and dynamics of a dying patient's family. But I've learned that even in death, there can be joy and peace. If you don't already have one, make a living while the amount of heartache it saves for both families and healthcare providers is immeasurable. Story 6. I am not a doctor or nurse, but I was a combat medic in the Army. After basic training and job schooling, I arrived at my first duty assignment. As a fresh private, I assumed most of my work would revolve around combat medicine, hence the job title. That's when I got my first taste of the Army's "don't get your hopes up" reality check. So no kidding. I am told I will be pulling medical coverage for a 15-mile ruck march. Here I am thinking, 1. People actually walk 15 miles? 2. What the heck is medical coverage? I don't even have an aid bag. How am I supposed to treat anyone? I got the typical NCO response, "Figure it out." So I started scrambling, looking for the friendliest faces in my medic platoon. Mind you, most of these guys had just come back from Afghanistan a few months earlier and had treated live combat casualties. Translation, there were no friendly faces. When you're the new private, you're at the very bottom of the barrel, and nobody likes you. After a few push-ups and some desperate scrounging, I finally managed to grab an aid bag. I was ready, or so I thought. I'd gone over my notes, mentally prepared for gore, broken bones, maybe even the worst-case scenarios. But what I actually got was the Army's greatest plot twist. The number one casualty every medic deals with, and you can ask any of them, is heat casualties. I had been assigned to a high-speed infantry unit. These guys trained hard, blew stuff up regularly, partied like Vikings, and drank like fish trying to drown themselves, but the one thing they didn't do, drink water. Not a single one of them hydrated, and because of that, they dropped like flies. Fast forward a few miles into the ruck march, my first casualty. I hop out like I am Captain Hero. Cool guy shades on, helmet unbuckled, thinking I looked way cooler than I actually did. In AIT, we covered heat casualties for maybe 5 minutes, and I was half asleep for most of it anyway. Back then, we barely got 4 to 5 hours of sleep a night, and never all at once. So there I was, Private Dong panicking on the inside. They didn't teach me this, or did they? Man, I am definitely gonna mess this up. Meanwhile, my NCO was screaming at me to hurry, yelling something like, "You're gonna make the walls sweat when we get back." Still, I stuck to what I had been trained to do. Ice sheets, shade, the whole works. I got the guy loaded into the truck, stripped him down, and started an IV. At this point, I was actually feeling pretty good. He was alive. I was doing okay. And then came the question, did you get a core temp? No, I did not. Now in training, this step was explained, but we never really practiced it. It involved a thermometer and one very specific method, something we called biting the silver bullet. Everybody joked about it. Nobody thought they'd ever have to do it for real. But there I was, holding the silver bullet. The power was mine. As I slid the thermometer down the path, I felt it give way. In my very limited experience, I thought, got it. Nope, not even close. Somehow, I had missed the mark. My NCO stared at me like I was the densest human alive. There's only one a-hole. How do you miss? Meanwhile, the poor casualty was writhing in pain. I may have applied a little too much force. I'd never seen a real backside outside of movies, so yeah, rookie mistake. After a heartfelt conversation with the casualty, I went in for round 2. And this time, bullseye. I finally earned expert status. I left the thermometer in and began paperwork. 5 minutes later, my NCO was yelling again, "Why is the thermometer still in there?" I blurted, "Sarge, I thought we had to constantly reassess." "Yeah, Private Dong, take it out. You don't leave it in like that." Needless to say, I did make the walls sweat. I even had to write an apology letter for unintentionally poking where I shouldn't have. But I got better as a medic. For God's sake, though, they never taught this in school. Story 7. Every once in a while, you have a student who, let's just say, needs a lot of coaching. Most of the time, students who didn't do the greatest already know they messed up. So I always start the feedback process with, "Okay, let's talk about what just happened. How do you think it went?" Typically, they start listing off all the dumb things they said and are upset that they didn't do better. The surprise of the situation and inexperience just kind of makes them nervous and awkward, but as soon as the wrong thing comes out, they're already inwardly cringing. So, after the encounter, we talked about better strategies. A piece of advice I often give, especially in the miscarriage and loss cases, is have a plan before going in. In other words, take a moment to anticipate the possible response to the news, prepare to answer common questions, and prepare to allow the patient time if they become emotional. Then make sure that you have an exit plan. Otherwise, many students get stuck in the room as I cry, not knowing what to say to wrap up without being callous. Tell the patient the next steps for both physical care and emotional help, and then give them an expression of warmth/reassurance and leave. Also, with miscarriage specifically, be prepared to talk about next steps in the process of conceiving again if the patient asks about it. And be sure to reassure the patient that this is common in early pregnancy and is not a sign that they did something wrong. Some of the best students I had used the following verbiage. Many women feel like they did something wrong when this kind of thing happens. I want to assure you that you didn't. Unfortunately, this happens in about amount of pregnancies simply because something in the very early process of conception just didn't happen to come together right. The next time you try, if you choose to, it's likely that it will be successful. You absolutely can try again, and we can talk about that when you're ready. Most couples can successfully conceive after this happens. In the meantime, I am so sorry you're having to go through this. It can be very frustrating, upsetting, and scary. Do you have someone here at the hospital with you today? I want to give you a moment to take this in. Whenever you're ready, I am here to answer any questions you have. I know that this can be hard to discuss with a partner, especially if they have questions as well. Do you want me to talk to anyone for you to help explain the medical side? We can arrange an appointment to talk all of us together, or we can call them now and I can talk to them on the phone. Do you have someone to support you through this process? Many women feel that they could use a bit of help navigating the emotional side of this. So before you leave, I am going to provide you with a packet of Into-On support groups and professionals who focus on the subject of loss and miscarriage. Many of my patients have found it so helpful to speak with people who have experienced this process. So it seems like I've answered all the questions you have for now. If you think of any more, don't hesitate to call us here at the office, and we'll be happy to answer them. The next step is that we will call you to set up. You can take all the time you need here. When you're ready, the exit to the lobby is to the right. I will see you soon. Shakes hand, leaves. Story 8. Infantry dudes are like cats when it comes to water. It's 2007, and my buddy and I are sitting out in the middle of the giant dirt patch known as Camp Bowls. A random monsoon just dumped on our heads, and now the sun is out, turning the whole place into one giant buns crock pot because, yeah, we forgot we were in the South. My battle buddy and I are on some random detail, testing out these brand new hospital tents about to be shipped off to war. We're on a smoke break, drying off like good little soldier medics, watching the infantry dudes scramble by in full battle rattle, moving from one training station to the next. These guys are panting, slipping in the wet clay mud, trying to stay upright, all while getting yelled at for breathing out of formation by a bunch of angry infantry NCOs. We think the group has gone by and disappeared into the tents next to us for their next round of yelling. But a minute or two later, my battle buddy goes, "Yo girl, check out Casper. Think he's gonna make it to the tent?" Homeboy is doing that slow shuffle that screams, "My legs are still moving, so I am not dead yet." His body is trying to sweat but can only manage that funky, overheated glow. He makes it about 15 feet from the tent before collapsing to his knees. His NCO must have smelled something was off because he storms out, barking orders, starts yelling about how the guy's just taking a nap or something. Typical infantry NCO behavior, real polite. Thankfully, the NCO isn't clueless. He realizes this guy is in trouble and grabs the ice sheet cooler. My battle buddy and I just stand there, ready to jump in if needed. We watch in horrified amusement as Sergeant Shooter, not a lifesaver, literally rolls the guy up like a burrito in 2 ice sheets, dumps the entire ice bucket on him, and walks away. Battle buddy. So, do we help this guy or just let him get off by his own NCO? We are medics. Probably shouldn't let people go down under a Gatorade sheet. So we grab poor Joe rolled in dirt, unwrap him from his useless little cocoon, and start hauling him over to our tent, which thankfully is cooler, has gurneys, and all the proper medical goodies. His NCO doesn't give a freak. He smells that private-level nonsense is going on and comes charging back, foaming at the mouth. Here's where I committed Super Army sin number 1. I left my battle buddy behind. I didn't have time for all that. Joe's stomach is cramping, his head is pounding, so I hobble him into my tent. I make him strip just down to his brown clingers. I am a lady. Throw some ice under his arms, up near his danglers, and get his feet elevated. The sergeant is still screaming. Joe is mumbling, and I am calling for a van to get him to an actual doctor. My NCO shows up with the van, immediately starts yelling at his NCO. Now my battle buddy's stuck between 2 screaming sergeants like a poor chihuahua between pit bulls. Meanwhile, I've got a guy so clammy and hot, I am pretty sure I could cook an MRE on his buns, and all I can think about is my next smoke break. And people still complain when medics tell them to drink water. Story 9. I have 2 stories, but here's the first. I had a patient in his 50s who was terminally ill. Over the course of his extended hospital stays and numerous surgeries, I genuinely grew fond of him. I also got to know his family well. He struggled with severe anxiety, especially as his condition worsened, but somehow I was one of the few people who could truly calm him when it mattered most. His partner was always at his bedside. Then, somewhat unexpectedly, he asked her to marry him. She had joked about it a week earlier, never thinking he'd agree. He had always said no in the past. But now, with time slipping away, he called her bluff. It happened to be a public holiday, and they requested a Christian priest to officiate. The only clergy available that day was a rabbi, which didn't suit the couple. I felt like I had let them down. Then somehow, I got roped into officiating. They were fully aware I wasn't legally qualified or experienced, but given the situation, our bond, and the urgency of his final wish, I agreed. Their whole family was there. I stood at his bedside, doing the best I could. It was bizarre, beautiful, unforgettable, and yet I walked away from that shift feeling physically ill, worried I hadn't done it perfectly. They don't teach you how to fake marry patients at university. Since then, having been married myself, I now know exactly what needs to be covered. A dying patient around 20 years old was waiting for an operation that could save his life. However, he wasn't consistently able to participate in his care. He wasn't able to follow certain requirements that would make the surgery safe. His mood was volatile, which is understandable for someone terminally ill, and he seemed particularly frustrated and manipulative. One Saturday mid-morning, he locked himself in the bathroom for over an hour, which wasn't unusual, but when he stumbled out and collapsed into bed, I had to check on him. I found evidence of him using medication in a way that could harm him. It was a real what do I do moment. Reporting it meant surgery would likely be off the table, but ignoring it could have put him at serious risk. I reported it to the team immediately. Within a week, he was transferred to community palliative care closer to home. I hope that time proved more valuable to him than remaining in the hospital, isolated from friends and family, pretending he could adhere to a surgical plan he wasn't capable of following. Story 10. Nurse, medicine/ER/palliative care. I was never taught that some people can smell cancer. I remember learning about DKA, diabetic ketoacidosis, and that some nurses can detect the sweetness on a patient's breath. I am not one of those nurses, but I do smell cancer, all the time. I work in a more rural facility, and we see a lot of palliative cancer care patients, so now it's a regular occurrence for me. A little over 2 years ago, I was finishing up school, and on my last week of practicals, I was assisting a woman off the toilet when I noticed a small amount of pelvic bleeding and a very distinct odor. She had already finished menopause and had no known or documented medical reason for the bleeding. She was also a poor historian due to dementia. I mentioned it to my instructor and buddy nurse, and they took my concern seriously. It turned out that the woman did have known cancer, which was not properly documented, but the family had decided not to treat it due to her age and overall health. It wasn't until a few months into my nursing career that I realized I am someone who can smell cancer. Now, where I work, I smell it often, and I expect it. We run a cancer care program out of the hospital, and an admin from the program is often sent over to assist. I do my best to keep their doors cracked for airflow in case the patient's family can smell it too. It's not an awful smell, but it's not something I'd want in my Glade wax warmers. If I had to describe it, I'd say it's a musty, almost yeast-like odor. The intensity varies from person to person, but the smell is always the same. When I notice it on a patient, I go back to their chart to check for known cancer. So far, I've only noticed the odor on one other patient with no documented cancer. But we do not investigate further. This patient is palliative, and an investigation would serve no benefit, even if cancer were present. Reproductive cancers have the strongest odors I've noticed. That's my little rant. I wish someone had told us that some people can smell cancer, like some nurses can detect DKA. I stay quiet about it with coworkers. Once I mentioned it, and one of them looked at me like I was off my rocker. I briefly questioned my sanity myself, then did a quick Google search. Sure enough, people can smell cancer. Story 11. 2 days ago in the ER, I reported a student for refusing to start an IV on a patient with HIV. They were being openly vocal and extremely inappropriate about it. I had no tolerance for that behavior and laid into them. Standard precautions exist for a reason. Treat every patient the same and move on with your day. Worst case, you take the medication for a month, deal with the nausea, and move on if there's a catastrophic slip-up. So of course, I went ahead and started the IV myself. Nothing gets my hackles up like that kind of behavior. Edit. Since there are a lot of questions about this, I want to clarify this is not medical advice. Do not take it as such. Please consult a doctor or physician for your specific case. There is HIV PPEP, or post-exposure prophylaxis. It is a month-long course of medication, usually Truvada and Isentress, which are also used to treat HIV. The data show that PEP is highly effective at preventing HIV infection if taken correctly. You might feel sick for the month, usually only for the first few days, but that's a side effect of the medication, not the virus itself. As long as PEP is started within 72 hours of exposure, it works very well, especially for lower-risk exposures like a needle stick. A needle stick is far from a guarantee of infection and is considered lower risk for seroconversion, but it's always better to be safe. Story 12. In my second year out of medical school, I was the on-call cardiology doctor. I got called down to A&E. Ironically, I had just finished my rotation there the week before. A woman in her 50s had been brought in after suddenly collapsing at home. She was in full PEA arrest. Before collapsing, she had complained of chest pain. The A&E consultant explained the situation. We had to decide whether to give thrombolysis, a clot-busting drug, in case she had a massive pulmonary embolism. That would mean doing CPR for a full 90 minutes afterward. Alternatively, we could wait for an echo to see if she'd had a sudden aortic dissection, in which case there was nothing more we could do. Then he looked at me and said it was my call, me, the least experienced doctor in the room. Okay then. I called my registrar, and we agreed to go ahead with thrombolysis. We also got ICU down to consult. I drew up and administered the drug, and then the 90 minutes of continuous CPR began. We rounded up every available staff member in the department, each person rotating every 2 minutes in a relentless cycle. Partway through, the patient's family arrived. They asked if they could see her. We covered her as best we could, and the family came in, one by one, to say their goodbyes. It wasn't looking hopeful. At that point, I had taken over ventilation. I stood there bagging while hearing each family member speak to their mom, grandma, or aunt. Some told her they loved her, others gently gave her permission to let go. The room was silent except for the soft rhythm of staff rotating around the bed, performing CPR. I stood there with tears in my eyes. After 90 minutes, we briefly got a rhythm, probably from adrenaline, but it didn't last more than 30 seconds. We all agreed to stop. As the consultant went out to break the news, we heard the family howling outside the door. It was absolutely heart-wrenching. We just stood there for a moment, silent. Then a nurse came in needing something prescribed for another patient, and everyone went their separate ways. I wrote up my notes, and that was it. I've never forgotten that lady or her family, and the things they said to her. I hope they know we did everything humanly possible to save her. We were physically and mentally exhausted afterward, but had to pick ourselves up and carry on to help other sick patients. Honestly, I still don't know how I made it through that shift. Story 13. When my wife started her career as a registered nurse, her first job was in an aged care facility. The hardest part, she said, was working with residents who had dementia and coping with the behaviors that came with it. She had residents who ate their own feces. One incident made her go home early, feeling sick for the rest of the day. Another time, a resident walked down the hallway with feces in their hands, completely unaware of what it was or how it got there. They even had to remove the Christmas tree from the dementia ward after a resident urinated on it. Some of the hardest challenges were the violent or aggressive residents. Many had been sweet, loving people before dementia took hold, though one resident had been an angry, abusive man before developing dementia and later became a kind, gentle old man. Working with these residents made her realize that aggression often comes from fear and confusion. Imagine being stripped of your identity, surrounded by strangers, and having someone undress and shower you every day. It would be terrifying and disorienting for anyone. It was also really distressing for her to care for residents who couldn't remember that their spouses had died, asking every 20 minutes where their wife was. Nurses quickly learned that the easiest way to manage this is to tell small, gentle lies. She's just gone to the pharmacy to get some medicine. She'll be back soon. One family trying to help made a beautiful photo album for their grandfather, showing pictures of him and his wife together, ending with photos from her funeral to help him remember that she had passed. But such reminders often caused residents to relive the loss every day, so the staff found it kinder to offer a gentler explanation instead. In short, many aged care facilities can be terrible, But if you find one with good nurses and staff, your loved ones can receive excellent care from people who genuinely love and care for them, even if there are occasional challenges. Story 14. Northern Idaho, 1948. Christmas. Gramps was an incurable prankster. Why or how he came up with this particular idea, I will never know, but apparently at some point in 1948, he decided it was time for the big one, a prank that would outdo everything he'd done before. The previous year had involved a large stump and 8 or 9 sticks of dynamite, so topping that was no small feat. Gramps was a hunter, of course, and during that fall season, he set aside several deer hooves and a quart or two of deer blood. Between hunting season and Christmas, he started voicing his displeasure with Santa, complaining that the man never brought him what he wanted. Come Christmas morning, Gramps promised, there would be a reckoning. Christmas morning, Gramps went out around 3 or 4 a.m. He tromped boot prints into the snow, along with sleigh tracks, hoof prints, and all the deer blood he had set aside. Then he snuck back inside, grabbed his shotgun, and tore through the house, shouting at the top of his lungs, "I got you this time, you wuss! Get back here!" He charged back out into the snow and fired several blasts into the sky for good measure. The windows on that side of the house were, of course, filled with 4 pairs of wide-eyed kids, followed shortly by Grandma, who had no idea this particular joke was in the works, and she reacted about as you might expect. Once she got the kids calmed down and back into bed, some serious discipline was delivered, but not by Gramps. There were, of course, long-term consequences. From 1949 until he died in 1997, every year Gramps received a double handful of walnut shells and a lump of coal in his stocking. We grandkids had heard the story from our parents, always with a "you kids don't know how lucky you have it." Why, in my day, Gramps would always go last when it came to emptying stockings. He'd pull his down, say, "Well, let's see what the big guy left me this year," stick his hand in, and pull out exactly what we all expected. Then he'd exclaim, "Oh, doggone it, he got me again. I am going to wait for him next year. You just wait." Story 15. Outback, Australia. After hours on the road, hundreds of kilometers from any town, and sometimes 700 to 1,000 kilometers from any decent-sized place. Sometimes there was a local health worker nearby, but often I was completely alone with only a Toyota Land Cruiser as my ambulance. I relieved various postings around northern Queensland, and over the years, I saw things that were both terrifying and unforgettable. I was called to a high-speed car rollover deep in the desert. I drove for 2 hours on unsealed tracks, finally arriving at a crumpled car. 4 people had died. The scene was surreal and heartbreaking. I had to focus on the task at hand, keeping calm and methodical, even as the gravity of the situation hit me. On another call, it was a suspected self-harm attempt at the edge of a dense tropical forest. I shone my torch and saw a figure hanging from a tree. At first, it looked like the person was moving. My training kicked in. I prepared to provide immediate care, but as I got closer, I realized the movement was due to ants and other insects. The body had been missing for a day, and the scene, though disturbing, was not what it first appeared. There were also moments of profound life and hope. One night, I delivered a baby whose waters had not broken. The little one was born safely inside an intact membrane. I later learned this is considered a lucky child in local folklore, with beliefs that such babies often grow up to be fishermen, never drowning in their lives. Other emergencies tested me in ways I could never have anticipated. A man was brought into the clinic with a severe leg injury where the skin had been removed from thigh to foot. I had to remain focused while providing care, aware that every movement mattered. It was like seeing anatomy come to life in front of me, a stark reminder of the fragility of the human body and the urgency of every decision. Rescue operations often involved improvisation. After a long time on a tiny beach island, a rescue helicopter finally arrived to airlift a young boy. I stayed on the sand, utterly exhausted, watching as the chopper hovered, the bystanders cleared, and the boy was finally lifted to safety. I later realized the crew had worried I might have collapsed myself and were worried I needed medical attention, adding a touch of unintended humor to an otherwise intense day. I am old now, and after they left, I just had to lie on the beach, completely knackered. There was a lot of awful stuff over the years, but also an awful lot of really perfect memories. Happily retired now. Story 16. So many things I've learned on the job. Here's what comes to mind off the top of my head. 1. Sugar is used to help reduce a prolapsed rectum. You sprinkle it on, let it draw some of the fluid out of the tissue, and then gently push it back in. That was an interesting on-the-job learning experience I never learned in school. 2. How to place someone in a body bag with dignity, especially if they are tall or in an awkward position. It's a humbling, somber skill, but one that matters deeply in respecting the person and their family. 3. Fournier's gangrene. One day, while precepting a patient care tech in the ER, a patient asked me to help him dress a wound unrelated to his visit. I called the tech over to teach her some wound care, and she learned how to maintain a perfect poker face that day. 4. Never block your own exit when in a room with an actively psychotic patient. That lesson was learned the hard way, and it's the kind of safety knowledge you never forget. 5. How to comfort an inconsolable baby. Low shushing in their ear, a firm swaying motion, and gentle humming can make all the difference. It's a delicate skill, but it works wonders. 6. How to interact with patients and their families on some of the worst days of their lives. How to hold a hand while delivering terrible news, and how to celebrate the rare moments of good news. Then, after telling a family their loved one has passed, how to leave the room, compose yourself, and care for the next patient as if it's just another day. Nursing is a profession that offers the sacred honor of being there for people on the best and worst days of their lives, to hold a life that is only seconds old, and to hold the hand of someone in their final moments. That is not something that can be taught in school. Story 17. I was about 20 and had repeated bouts of severe stomach pain. My GP wasn't very attentive, so I was sent for a barium enema. I understood the procedure, but I was unprepared for how intense it would be. I arrived half an hour early and checked in. At the front desk was a nurse I recognized from a part-time job I'd had at a vet surgery. She had been a client there. We struck up a conversation, and I asked if she was free to hang out sometime. She gave me her number, and we exchanged a few friendly words before I was called in. The doctor explained the procedure and gave me a robe. I changed and got on the table as instructed. At first, it felt uncomfortable and intense, the kind of bodily reaction you can't really prepare for. Tears rolled down my face, not from sadness, but because my body was reacting naturally to the procedure. Someone gently held my hand to provide support, and I looked up to see the nurse smiling reassuringly from the room. That small gesture broke the tension, and I felt a mixture of embarrassment and relief. Afterward, we did go out a few times, but our schedules never quite aligned, and it didn't last long. Still, I remember that day as an odd mix of challenging, awkward, and oddly comforting. Story 18. If you're able to pass stool normally, you probably don't need any tests. For me, my back muscles gradually started to feel paralyzed. I couldn't control the muscles properly. Over several years, it became harder and harder to relax them when trying to open my bowels. Week by week, the muscles felt more fatigued and less responsive, as if I were forgetting how to tell my body what to do. Eventually, I had to assist myself manually because my muscles weren't responding. When I did, stool would pass as it should, and I was finally able to go. It took a long time to explain this to my doctor, who initially thought I was scooping out compacted stool. But that wasn't the case. My muscles were essentially clamped shut, and the stool was simply waiting for them to open. I never got a definitive answer for why this happened. Doctors noted it's common in women with chronic pelvic pain. I have endometriosis. Pelvic floor retraining didn't help much. Over time, it just improved on its own. A few years later, the issue returned, then improved again. Right now, it's back to being quite severe. My current doctor has suggested tethered cord syndrome, where the spinal cord is attached to the base of the spine, causing nerve dysfunction in the pelvis. This could explain other issues I have, such as basal headaches, lack of bladder sensation, and foot drop. Given my connective tissue disorder, tethered cord is a high possibility. However, rectal prolapse or a simple pressure-related nerve issue in my pelvis are also plausible. Pressure-related nerve issues are episodic in my condition, which makes sense in this context. I am hoping to see a connective tissue disorder specialist soon. I've been on the waiting list since 2015. I am not in America. There's only one hospital in my country with an adult CTD specialist who can handle my specific issues. Living with this has been a slow and frustrating process. It's taught me patience, persistence, and the importance of advocating for my own health. Even though I haven't yet received all the answers, I continue learning about my body, monitoring changes, and navigating the medical system as best I can. Story 19. You have to keep in mind that this training is all done in 4 months. 60 weeks are the jacks of all trades in Army medicine. You're trained in every aspect of the role, but the main priority is combat medicine. Most days are spent in a classroom, being PowerPointed to death or practicing IVs on each other when not in class. When you're in garrison, what we call our unit, post, or whatever, when you're not deployed, you rarely use combat medicine. People aren't getting shot or blown up. Yet the bulk of your training focuses on treating those who have been. The amount of knowledge and skill packed into those 4 months is immense. In class, you might go from learning how to treat a heat casualty 1 hour to cutting holes in patients and inserting tubes the next. Clinical time is limited because there are over 1,500 soldiers training at once, so accommodations just aren't feasible. You can make AIT harder or longer because medics are essential assets to infantry units. On the line, it's typically 1 medic for about 30 soldiers, and every unit is short on medics. The course wasn't glossed over, but instructors can't focus on a single topic for too long. You take a test every 2 to 3 days, and if you fail, you're sent to a cycle 3 weeks behind. A lot of people fail. An exceptionally good class might retain 75 to 80% of the original group, but only 40 to 45 actually graduate. It's an intensive course, and it makes sense by the end. You work with what you have. Some soldiers teach supplemental classes to newer privates, focusing on what they'll treat most often. Medics have to be resilient, ready to learn, and able to absorb information quickly. Story 20. Unfortunately, I've had to do this far too often, usually to a family I've only known for less than 5 minutes. How do you tell a wife of 40 years that her husband has died, especially when she insists he wouldn't want to ruin Christmas Eve by coming to the emergency department? How do you face a distraught family member as you pronounce their loved one dead less than an hour before the New Year's ball drops? Or a young 20-something John Doe who overdosed and is now, at best, brain dead on a ventilator, and you have to track down the correct next of kin through police, social media, and other means. Or a former 30-something veteran who couldn't cope with PTSD and his pregnant wife, now brain dead and ventilator dependent. Or a son requesting his father, whom I've been coding for 50 minutes, be flown for a heart transplant, something that simply doesn't happen, only convinced otherwise after calling a cardiologist. Or trying to keep a child's brain injuries discreetly out of view after a serious car accident. Or telling a patient on Easter Sunday that their persistent fatigue is due to a football-sized lung mass. Or informing a man in his 30s that he doesn't just have an infection in his leg, but stage 4 colon cancer with metastases to his liver. Or watching a husband honor his 75-year-old wife's wishes to avoid further intubations, staying faithfully at her bedside as the admission team downgrades her care. Unfortunately, these are only a portion of the sad discussions in a few short years of practice. Medicine, like much of life, is humbling and brutally cruel. Story 21. How to cry with a patient when they learn they have end-stage gallbladder cancer and choose to become DNR to focus on comfort and go in peace. How to fight with doctors to ensure proper pain management so they don't suffer, and then hold that patient's hand when they thank you for advocating on their behalf when they couldn't find their own voice. How to handle a patient who continuously threatens staff because their blood sugar is unstable, then becomes physically disruptive, throwing objects, screaming profanities, removing their gown, and attempting to strike staff, requiring security and eventually police intervention. And how to remain composed when your manager tells you to get this patient their meal and let them eat with 3 security guards present after everything that just happened. How to react and pull yourself together when you walk into a room and find a patient you've cared for weeks unresponsive, unable to be revived, and then cope with the aftermath. How to watch a patient with esophageal cancer who's been on your unit for months deteriorate rapidly and realize that the end is near. That was the longest code of my life, lasting 10 to 15 minutes. Everyone on the unit cried when the time of death was pronounced. How to handle a patient making suicidal comments or gestures toward you while maintaining professionalism and safety. How to leave a shift with scratches and bruises from a patient with dementia after providing routine care and cleaning following incontinent episodes. I could go on forever. Story 22. For context, I am a veterinarian. I graduated last year and am 6 months into my first job out of school. I was on call when a case came in involving a cow having trouble calving. Normally, nothing I haven't handled before. It turned out the owners had tried to help the cow themselves, roping it and tying its legs to a horse. Unfortunately, all they managed to do was make the cow very agitated. When they arrived at the clinic, the cow was understandably upset. I couldn't use the nice roomy chute designed for this kind of procedure, so I had to use the hydraulic chute instead. It's more cramped, which makes pulling a calf much harder. I reached in and felt the back legs, not the front. That's a problem. To make matters worse, the calf had already passed away and its hips were large. There was no way it would come out naturally. Normally, a C-section would have been necessary if the cow hadn't decided it was the perfect time to lie down in the chute. We had to carefully maneuver the calf out through the front of the chute. Thankfully, nothing broke during the process. After that, it was a slow hop, skip, and drag to get her back to the trailer. She struggled to stay standing, alternating between attempting to rise and resting on the ground for stretches in between. One thing I haven't mentioned, it had been snowing non-stop since early morning, and the temperature was well below freezing. We secured her head and legs, and I started getting everything ready for surgery. Overall, things went smoothly from there, until I set down my scale, which had some blood on it from routine handling. Later, when I went to pick it up, it had frozen to the metal instrument tray and knocked the tray into the snow. I managed to complete the procedure and sewed the cow up. To this day, I don't know whether the calf survived. Story 23. My mom's a pretty tough lady. She was a nurse, worked in respiratory, then hospice, and had countless stories. The only time I ever saw her break down and cry was for a 92-year-old man. He was actually in decent shape for his age, but was reaching the point where things were failing, and he walked into the hospital ready to go. He'd been in their care only a few days when some system, maybe his heart, shut down. Somehow, he didn't have a power of attorney, so he was resuscitated. Word got out to his family, and people started popping out of the woodwork. Children, nieces and nephews, grandchildren, all with reasons why he couldn't be allowed to die. This might have been a sweet story if they had flocked to his bedside to say their goodbyes, but they didn't. Not a single one. Instead of a nice old man who walked into the hospital under his own power and passed away on his terms, he ended up with bruises all over his body from struggling with the nurses and had to be fully restrained because he kept trying to pull out every tube and IV. My mom was his nurse for the last week of his life. She had to keep that poor man alive, and none of his family ever came to see him. The day before he finally passed, he had given up fighting, but every time she walked into the room, he tried to say, "Please let me die," and "Please help me," despite all the tubes. I don't want to put it as a parent comment because it's secondhand and I don't remember all the details, but I imagine they don't teach you this in nursing school. Nurses are heroes. Thank you for watching. If you enjoyed this video, be sure to give it a thumbs up, subscribe, and hit the bell icon so you never miss an update.